All right, good afternoon, everybody. Thank you so much for joining us. Happy Thursday. Welcome to A Shared Vision, Building Community Partnerships for School-Based Eye Care Programs. And we will have you here for 1 hour to learn, and hopefully you'll be able to ask some questions today. Some quick reminders before we get started with content. You all are in listen-only mode. So if you do want to ask a question of our panelists, we ask that you use the Q&A icon at the bottom of your Zoom control panel. If you would like to turn on closed captioning, you can press the CC button that you'll find down there as well. We also ask that you complete our evaluation poll questions at the end of our presentation. And then also, we will be sharing the recording, slides, and additional resources next week following the webinar. I'm Harper Byers. I'm a coordinator at the School-Based Health Alliance, and I am joined today by my colleague Danielle Dobbins, who I will pass it over to right now.
Thank you, Harper. I want to take a moment just to introduce our featured presenters this afternoon, depending on where you're joining us from. So I'll start off with Dr. Chow. She's a physician and public health leader and the founder of and as well as the executive director of Envision Eye Care for All, which is a nonprofit launched in 2023 to expand access to comprehensive eye care through partnerships with both rural health clinics, schools, as well as school-based health centers across Oregon. She served in national as well as statewide professional roles, which include the Association of Clinicians for the Underserved and the American Optometric Association. Her leadership has been recognized with the Oregon Optometric Physicians Association with the Apollo Award. She was also awarded the Golden Opportunity Award from the American Optometric Association Foundation, as well as the Mobile Health Impact Accelerator Program from the Harvard Medical School's Mobile Health Map. I also want to introduce you to Dr. Baker. She is the Director of Vision Services for Cherry Health, which is a large health center based in Grand Rapids, Michigan. Dr. Baker is a graduate of the Michigan College of Optometry, as well as a fellow in the American Academy of Optometry. She joined Cherry Health back in 2011, following her completion of the ocular disease residency there. And then in 2017, she launched a community health and primary care optometry residency program where she mentored 6 optometrists. She guided them to develop advanced clinical competency, as well as develop a deeper understanding of community health. Dr. Baker also serves as adjunct clinical faculty with the Michigan College of Optometry and has precepted 4th-year optometry externs for over a decade. Her role as director, in her role as director, she's also responsible for the clinical as well as business operations of a multi-site vision services department. So she has experience with both urban as well as rural health center settings, mobile clinic operations, implementation of diabetic teleretinal programs, as well as recruitment and hiring, building clinical schedules, developing budgets, as well as supervising a large staff, including optometrists, opticians, as well as optometric technicians. So we welcome both of them, and I'd like to turn it over to our partners for this presentations to also introduce themselves.
Thanks so much. I'll start. I'm Donna Fishman. I'm the Executive Director of the National Center for Children's Vision and Eye Health at Prevent Blindness. Luke?
Good afternoon. I'm Luke Erdahl. I'm the Program Director with the Association of Clinicians for the Underserved. Great to be with you all today. Harper, I'll turn it back over to you.
Sweet. Thank you both so much. I did want to just highlight that if you wanted to learn more about the work that the School-Based Health Alliance does, to check out our website for toolkits, resources, and more information about the work that we do for the field and with the field. And with that, I welcome Donna back to share a little bit more about her org.
Thanks so much, Harper. And I just want to thank the School-Based Health Alliance for their partnership ECU, the Association of Clinicians for the Underserved and Prevent Blindness, are really honored to be co-sponsoring this webinar today and to welcome all of you. We have a very simple mission at Prevent Blindness, which is to prevent blindness and preserve sight. We do that through education, policy work, policy advocacy, and then patient empowerment. And so we welcome you to check out our website at preventblindness.org. The National Center for Children's Vision and Eye Health improves children's vision through, as you can see, strong partnerships, sound science, and targeted public policy. And we work in a few different areas. One is professional education, which this is part of that. And then public education. We have a lot of resources for educating parents, guardians, families around children's vision and eye health. We have a training program. We certify people to be evidence-based vision screeners all the way from birth through high school. And then we have community programs, and we provide technical assistance, and we are here for all of your vision needs. And we have a forum online, and I can put that in the chat if you wanted some technical assistance around children's vision. Thank you. Turn it back to you, Harper.
Thanks, Donna. It's been fun to work together on these webinars, and I've learned a lot, I know. So excited to dive into content today. So our learning objectives for the session are that you will be able to identify key partnership types that can strengthen and expand eye care access for school-age children, describe practical strategies for building and sustaining partnerships, including roles, responsibilities, and workflows that support eye care delivery. And lastly, apply lessons from programs serving various populations to develop or refine an eye care expansion plan tailored to participants' local needs and capacity. And with that, I'll pass it over to Dr. Baker. Oh, and you're muted.
My audio.
Welcome back. Been there.
Oh, good afternoon, everybody, and thank you for joining us, and thank you for the kind introduction, Danielle. But yes, Megan Baker, I'm an optometrist at Cherry Health. We're a large health center in West Michigan, and we have a really robust school program, and we deliver our care with a couple different modes of practice. So I'm going to discuss our partnerships as well as a couple of ways that vision care can be provided in schools. So like I had said, we are in an urban area primarily, and we are partnered with several large districts, and we were recently able to expand to 2 full vision teams, and I anticipate we'll see about 4,000 kids in our partnering districts this year. We deliver care 2 different ways. We have a team, which includes an optician or an optometrist, an optician, a technician that work physically in our partnering schools, and we do move their equipment in and out of those schools. We also were able a few years ago to purchase a mobile vision clinic, which has 2 exam rooms, and that is how our other team provides care. Same kind of setup with the team, except there is, of course, a driver who does also do some kind of receptionist or administrative work. We do have optometry residents at our site that also see children in our school vision programs. We typically, as just our model goes, prioritize seeing the kids in their elementary and middle schools in our partnering districts. These students receive all of this care at no cost, and they do get a comprehensive dilated exam, and they do get glasses. We do have the benefit of having a brick and mortar clinic, so any students that do require any follow-up are able to be seen at our brick and mortar clinic at a later date. Regarding kind of planning one of these projects or services, of course, the first relationship or partnership that will need to be developed is going to be with the school districts. And so we did outreach to superintendents and principals and school nurses when we were first launching this program. And we were looking at schools that we anticipated a high need. We started by looking at kind of percentage of kids on the free and reduced lunch program. And then, scheduled meetings and did some education on what comprehensive vision care looked like and how it was different from screening and, how it could really benefit their students. So that's the first and most important partnership. I will say that having good relationships with school nurses has been incredibly important. They're really great advocates for the program. help to get kids consents completed, identify kids that are really in need of services. And so that's a really important relationship to develop. We also, from a financial sustainability standpoint, have some community partnerships that have been really important for us. We have been generously supported by our local Grand Rapids Lions Club for a number of years. They provide a lot of funds and raise a lot of funds for our entire brick and mortar as well as school vision program, including like paying for glasses or exams. We don't necessarily need that in the school for patients that cannot afford it. We also use Essilor's Saving Sight Through Lenses program. They will provide free glasses to patients or students that do not have any insurance. I will say too, there's often a lot of grant opportunities out there for expanding access to vision care for students as well as mobile delivery of vision care. However, that will vary state by state, but it's certainly worth exploring. I'm going to talk a little bit about program logistics just to get a bit of an idea of what can be involved in the logistics of planning. We started small, and at that time we did paper consent our students. As we found out, and as most will, a lot of what goes home with a student doesn't necessarily make its way back into the hands of the program. We were able, through a number of years, to work with the IT departments at our partnering districts and move to an electronic consenting process that takes place during the annual enrollment in school. And that has yielded much more participation in our program, and we've been able to see a lot more kids. We do check insurance and we do bill insurance. So kids that are eligible or uninsured are seen by our program. If they are exhausted, then we know that they have an existing relationship with an eye care provider, and so we don't see them in the school program. But checking the eligibility also helps us determine our moves and as well as what school we're going to go to when we have a kind of a ballpark estimate of how many kids need to be seen. When you're looking at moving into a school, the day-to-day is really unpredictable, and so you have to go into it expecting that. You are going to be working around days that are half days, early releases, school assemblies, testing days. And so you do have to bring a lot of flexibility to these programs when you introduce them. And then we always want to keep the parents informed because they're not there for the exam. So we do send a letter home to parents with the child as well as a copy of their glasses prescription. But if the student needs additional services or did get glasses, we do take the extra step to make calls and mail the paperwork home. We want to make sure that parents feel like they are well looped into the care their kids receive when they're seen by us in their school. This is just some photos of our mobile equipment that we move in and out of the school. We do have 2 lanes of equipment because our optometry resident is often out there. We used barber's chairs, but you of course could use any chair that the school might have. And then we have 4 opters on a tripod situation. We just use a long 8-foot table to hold our exam equipment. And then we use the M&S visual acuity system on laptops to check acuity. This program is nice because it's very easy to recalibrate the distance from one school setting to the other to ensure you're getting accurate visual acuities. But a fairly simple setup for the program. There is definitely some setup and breakdown time, and we can talk about that a little bit later. But this is kind of what our setup looks like in a pretty large space. We don't always get as much space as what's seen in this photo here. This is a summary page, and actually, Harper, you can advance past this. We're going to talk about some of the just benefits of each type of delivery that we do, whether that's moving into the school or on our mobile unit. But we're going to start with the moving your equipment in and out of the school. And this is definitely the easiest starting point. This is much lower startup cost. A mobile vehicle is quite expensive. So most of the time when people are introducing this service, it will be in this method by physically moving equipment. When you're in a school, you will often have a little bit more space than you may on a mobile unit, although that is not always the case. And in fact, that was one of the reasons why we ended up with a mobile unit, is that we had a district that couldn't reliably give us an adequate amount of space to do the exams. When you're physically in the school, the staff do have direct access to the restrooms, the break rooms, which is a little bit easier for them. And you don't have any of the safety concerns or the logistics of moving a student outside the school. So the students stay in the school. It's a little easier to move them around. It's a little easier to get them down to the room. And some of the doctors that work in the school just feel like it offers a better ability to build relationships and have communication with teachers and school staff when they're physically in the school. This method typically also requires a little bit less staff because you don't need a driver necessarily. But it also requires, as I'll talk about on the next slide, a lot of cross training of staff. So that can be viewed as a downside. We also find that with the exception of the moving days, the clinical day is typically longer because we're not having to coordinate around the school busing schedule or patient pickup, which can shorten the clinical days. And we connect to the school's Wi-Fi or internet network when we're there, and we find that to be a little bit more stable than our network that we have on our mobile vehicle. You can advance. There are some pros and cons of all of these things. So when we're physically moving, we typically do have less available equipment. We do not have slit lamps with this team, but we do on our bus. We also have a retinal camera on the bus. And, there is definitely some wear and tear. We've got 2 full exam rooms, which we move with a truck and trailer. And there definitely is some wear and tear and damage to equipment over time. The space, like I had shared, while we may have slightly more space, it might be very difficult to work in. You don't often have control over the space or the lighting. You may be in a really well-lit room, which may make some of the exam components difficult. The other thing we have run into is that often schools will displace staff to create room for us, and that is not always something that staff enjoy. And so we have had to navigate some dissatisfied school staff related to their displacement. You do need to cross-train staff when they're out there because it is such a small team. And with our in-school team, we do try to prioritize larger schools because the move is a little bit laborious. It's easier we're a little bit more nimble with our mobile clinic. So we can see it's easier to see smaller schools because we can just pick up and move that even in the middle of the day if we need to. And that's really not the case when you're moving your equipment in and out of the school. So we have the advantage of being in a large urban area with large schools. And so it is not hard for us to identify schools where we will be there for 2 weeks, a month. And so that's a good setting for this type of delivery. There are a lot of logistics to the moving. That's why you need to know how many kids need to be seen. So you can set up how many days you're going to be there and you can coordinate with the mover. Now, some people move their equipment on their own. We have a company that does that for us. And there's not really any patient privacy. As you saw, that was a wide open room. The kids generally do come down in a group, so it can get a little loud and chaotic. And, there's a lack of patient privacy with this model. This is our mobile clinic, and it has 2 full exam rooms. It does have an optical space. We do take the same frame selection out with our in-school team as well. We just use a rolling. It's a like briefcase type thing that's made to hold frames of glasses. But yes, we are pretty proud of this vehicle, and it is nice representation for our company when it's seen around the community. And this, again, is just a summary of what we'll talk about. The advantages here is, from the perspectives of my doctors, is that you do have full control of the exam space, and the exam space is consistent. So you know where everything is. You know how everything works. You have control of the lighting. We are not, displacing staff or occupying space in the school. It is their own space. Like I had just shared, it's slightly easier to accommodate a smaller district because if you have a couple days of kids, you can easily pick up and move. The other thing that we are using this for other programs outside of school vision. So we are using this at community events to do vision screenings, and we are partnering with some other health centers in our area to provide some vision services to their patients as well. So when you have a mobile unit, you can use it for things kind of outside of the school setting. There's not any lost clinical time on a bus related to moving, but there is some lost clinical time on a bus related to parking. And we'll talk about that on the next slide. But There is better patient privacy on our vehicle because we do have exam rooms. The doors can be closed. And the doctors feel that students behave slightly better on the bus. I don't know if that's always the case, but perhaps. It is set up a little more, it looks a little more like a regular doctor's office, and there's some novelty for especially elementary kids to be able to go out of the school and onto this bus. So maybe not, but that was what they reported. You can advance. I will say we like having our mobile unit. We were able to buy this unit basically completed from Southern College of Optometry, which made this much more accessible to us. This type of vehicle is quite expensive. So going down this road, there's really high startup costs. And there's a lot of ongoing maintenance, just like you would have with a brick and mortar clinic that you wouldn't have if you were inside of a school. There is a generator which needs to have oil changed every 6 to 8 weeks. You have fuel expenses. We had a large kind of unexpected need to install a furnace. And so there are anticipated and unanticipated maintenance costs that come up in this type of situation. And while the space may be consistent and reliable, it's not a huge space. Our RV is 38 feet long, and 2 of those things are exam rooms. So there's not a lot of extra space. And it is in a vehicle. So yes, we have air conditioning, and yes, we have a furnace, but you are still subject a little bit more to the elements. And if you need to, the staff have to go into the school. They have to be badged in or let in by staff to use the restroom, use the break room. The students have to be brought in and out. And, if it's raining or snowing, you are dealing with all of that, getting the kids' coats on, and you're more subject to the climate when you're in a vehicle. The other thing is that when you go this route, you have to have a driver. And I cannot stress enough how important it is to have a driver that is willing to do things beyond driving, that is, flexible and innovative and can kind of run the general operations on the vehicle. And it took us a few tries to find a really good fit here. But if you want this program to work well, the driver is a real key component. Our driver does have a CDL. That is not necessary for certain types of vehicles, but we felt from a safety standpoint that was important. So something that can be taken into consideration. The days can be shorter. If we have to park in a bus lane, then we have to arrive later and leave earlier. If we're in a parking lot that parents do pick up in, it can be impactful. So it can cut down your day by about an hour on a bus. I do have some staff I can't put on the bus because they get motion sick even when the bus is not in motion. And while we do have a network on the bus, the internet connectivity is a little bit more variable on the vehicle. Yeah, those are the two, you can advance. Those are the 2 ways that we deliver care. We do glasses as well as part of this program. If kids have Medicaid benefits, we send those to Classic Labs. If kids do not, like I had shared, we use the EssilorLuxottica Foundation. They do provide a frame selection for the kids to choose from, and they're provided at no cost, including multiple pairs for kids. If you have students that would benefit from having a pair of glasses they leave at school and one that they can take home, Essilor will certainly provide that. And we do provide replacement glasses for kids as well. The parents can just call our brick and mortar. They are given instructions on how to do that, and we will order replacement glasses. So we never want these kids to go without glasses, and we definitely will help them out if they are lost or broken. This is a summary, and you guys will get the slides of kind of everything we talked about, but it's been interesting to have 2 ways of doing this. And I have the doctors that do this care, they think they're both great. They've adjusted to both of them. Some of them feel that there's, outweighs the other, but ultimately I find that both are great and that staff acclimate to either. And at the end of the day, the most important part is that we're providing care to kids that need vision care. And so I definitely encourage this. I think it is a good way to provide some access to kids who need it, but I would certainly recommend pursuing grant opportunities and partnerships in your community or with your state the Lions Club, there are local clubs. There's also Lions International, which has some matching grant opportunities. So definitely some funding sources out there if you develop the right partnerships.
Thank you so much. We're getting some great questions in the chat here, and we will return to those later. I am happy to pass the slides over to Dr. Chown. Thank you.
Thank you so much, Harper. And thank you for the kind introduction. Thank you, Megan, for sharing your program. So Envision Eye Care for All. And in 2022, I began working with the Vision Services Committee at Association of Clinicians for the Underserved. And later that year, I became the director of outreach for an education-based mobile vision clinic. It was during that time that I discovered significant gaps in access to eye health and vision services. The framework that was created to take care of the health of our underserved populations varies significantly from state to state. Here in Oregon, eye health and vision services are missing from federally qualified and school-based health centers. It was for that reason that Envision Eye Care for All came to be. Next slide. We are a 501c3 nonprofit organization founded to address the inequities that exist in access to eye health and vision services. Next slide, please. Envision Eye Care for All provides comprehensive eye exams and glasses at no out-of-pocket cost, both to the individual and the community partner organization. We serve 3 rural counties here in Oregon, including Hood River, Wasco, and Gillum County. We also provide vision screenings, outreach, and education services. The barriers to care are different for every community we serve. These barriers may be financial, geography, or language-based. In Hood River County, many of our patients use Spanish as their primary language. In Gillum County, there are large geographic barriers that prevent families from accessing care close to home. One of the largest impacts we have is not just in the care that we provide, but in collecting and understanding those barriers to care while advocating for eye health and vision services to be embedded in the healthcare infrastructure for the underserved. Every community we serve is through a dedicated partnership. We understand that the community-based organization we partner with has developed the trust and also understands the needs of their population best. We rely on these relationships for communication and scheduling. Also, our funding comes from private grants, county government funding, individual and corporate donations, as well as fee-for-service billing. Next slide, please. We provide these services because we know that barriers to access exist. We also know that over 23 million Americans have a visual impairment, and 80% of vision loss is treatable and preventable. Most importantly, 2 out of every 5 children in the United States has an undetected vision problem. We also know that those detected vision problems, the follow-through, we also know of those detected vision problems, the follow-through from screening to comprehensive care is a real concern. Our program works in partnership with screening organizations to identify the children who have vision problems and provide the follow-through care to improve vision and ultimately improve academic success, behavior in the classroom, and overall health outcomes. Next slide, please. In the state of Oregon, we have 32 federally qualified health centers and 88 school-based health centers. Our program partners with rural health centers, school-based health centers, directly with schools and school districts, and child development coalitions to provide comprehensive dilated eye exams and glasses. We also partner with the Oregon Lion Sight and Hearing Foundation, one of the providers of the vision screenings to school-age children in our state. We provide outreach and education services at Mercado del Valle, which is an organization through Gorge Grown Food Network. Next slide, please. We currently use a portable model to provide our mobile vision care. We transport all of our equipment in heavy-duty toolboxes that fit like Legos in the back of a car. This equipment includes a phoropter stand, an M&S acuity monitor similar to the one that Dr. Baker was discussing, slit lamp, autorefractor, handheld devices, stereo and color vision tests, as well as a retinal camera, just to name a few. We utilize electronic health records, which allow us to coordinate care with the primary care team advanced care, and family as needed. It takes approximately 15 minutes to unload and load the vehicle and 45 minutes to set up and break down a clinic. Next slide, please. Our process starts when an organization reaches out to establish a partnership. From here, we conduct an interview to determine the organization's needs and how our services might align. We then conduct a site visit and complete all necessary paperwork, including memorandums of understanding and insurance documents. Next, we determine how many clinics are needed and which dates are open for both the community partner and our organization to schedule. Next, we determine if the student needs to be screened or if a partner organization has already identified the students of highest need through screening protocols. The community partner then schedules the patients on the predetermined clinic days. They also distribute our consent forms and patient history forms to the families scheduled. We provide comprehensive dilated eye exams and order glasses for students when needed. If more advanced care is required, the patient is then referred to the nearest pediatric-specific eye care provider. Approximately 1 month after the student is seen, we return to distribute the glasses. Each student gets a bag with their glasses, a case, a cleaning cloth, spray, and a care sheet. Our optician adjusts the glasses at distribution, and our community health worker then follows up 2 to 4 weeks later to check in on the student or family and see if any changes or follow-up care is needed. Next slide, please. As I alluded to before, the state of Oregon has a very robust vision screening program. In 2014, the Oregon State Legislature enacted rules requiring vision screening for every child aged 7 or older entering the public school system. These screenings are conducted using photo screening devices, such as the Welch Allyn Spot Screener or the Plus Optics device. These devices help to identify refractive error, anisometropia, or a difference in prescription, anisocoria, which is a difference in pupil size, strabismus, an eye turn, or risk factors for amblyopia, one eye that doesn't see as well as the other. The Oregon Line Sight and Hearing Foundation is one of the approved vendors for the state of Oregon, and they conduct the majority of the school-age screenings across our state. We partner with the Oregon Line Sight and Hearing Foundation by coordinating our schedules and not overlapping services. Once the Oregon Line Sight and Hearing Foundation arrives, they conduct the screenings and provide the results to the school nurses or the administrator. We schedule our services approximately 2 weeks after the Lions have screened the students. The nurse will then send home the screening results along with a consent form for our services. Families must opt in for care. Most parents also accompany their students during their scheduled appointment time. We dilate most students and provide glasses when necessary. Last year, 91% of the students we saw required glasses. Next slide, please. Here's an example of one partnership. This partnership is with the Hood River School-Based Health Center, One Community Health, and the Hood River County School District. So how this partnership works is we bring in our equipment and we set up our equipment in an exam room, which is now then converted to an eye lane. Their lab area where they run tests was also converted to our optical, and this was the very first patient that we ever saw. Next slide, please. The second partnership I'd like to tell you more about is the Gillum County and Condon School District partnership. This event takes place at Condon School, and we set up the exam area on the stage behind the curtains for privacy. And then our optician sets up below the stage in the multi-purpose room to measure and fit the children for glasses. And here's an example of a mother and daughter looking at some stereo vision tests. Next slide, please. So the portable model does have its limitations. A partner is always required to provide the physical location, and every location has its own unique setup challenges, like where we're going to be for the day, what the space looks like. So, for example, setting up on the stage versus setting up in an exam room, or that could be like a lounge or any space that's available for care. The date and the time is limited to the availability of our partner space. So schools oftentimes have lots of events running. And so finding that time that works for us to take over their space to provide the care is really important. Also, the time for setup and takedown decreases the number of patients that can be seen. And the mobile, I don't find it to be quite as efficient as or the mobile portable. I don't find as efficient as setting up in an actual vehicle itself. Also, moving the equipment around is physically demanding. Next slide, please. So at the time that I submitted my slides, we were still awaiting final funding for our vehicle, but we have actually just finished our funding. So we have on order currently a 25-foot Winnebago. This does not require a special driver, so I plan to be driving this vehicle. And we'll have a full exam lane in the back, and then we'll have our optical in the front. Next slide, please. And so our staff consists of just two. We have a very simplified process, if you will. So I am the executive director. I'm also the clinician. I'm also the grant writer. So I wear a lot of hats within the organization. Anna, my assistant, also wears a lot of hats. She is the optician. She's also an Oregon State qualified medical interpreter. She's also our community health worker. She is bilingual in Spanish and English, and she's also bicultural. We both have a lot of years in healthcare, as well as business management and eye care in general. Next slide. Thank you so much. I'm happy to have any of you reach out if you have questions that I can answer for you that don't get answered in today's webinar. This is my email.
Alrighty, thank you so much, everyone. We now have a bunch of time for questions, which is great. I know Danielle's been collecting those as we've been moving through, so I will pass it over to her, but keep them coming. We've got a lot of time to answer these, and just let us know if you have a specific presenter in mind for your question or if it's open to both of our presenters. So thanks.
Thank you, Harper. And thank you all of our attendees. You guys have been so engaged in sending in some great questions. So we'll start off. The first one is really for both our presenters. Attendees wanted to know about how many patients do you see a day? And that whoever wants to jump in.
I can take it. This was a number of years in the making, but if it's a single doctor out there, they typically see 16 patients in about a 7-hour day, working around lunches. If there's a clinician and a resident, then they see 20 to 22.
And our program sees about 10 to 12 a day.
Awesome. Thank you both. The next question, Dr. Baker, this one came in during your presentation, but the attendee wanted to know, how do you collect and monitor data for children moving through the screening to care pathway? And then how do you measure that equity?
Yes, we're not actually linked in with the Kent County Screening Program. That's another reason why it's important to have a good relationship with the school nurses, because we are not doing eye exams only on kids who have failed screening. We're doing eye exams on any parent who opts in for services and has an eligible child. So we are doing exams far in excess of kids that may or may not pass the county screening. Our county, though, so when a student doesn't pass a vision screener in Kent County, they are sent home with a letter, and it does have my brick and mortar clinic's information on it as one of the options to schedule an exam. And our county does follow up with the parents to ensure that's completed.
Thank you. This next question is really for both of you. Questions came in during both your presentations about partnership. So can you talk more about how you initiated partnerships? Dr. Baker, I believe you mentioned reaching out to nurses and school administrators. The attendee is saying that they were trying to do something similar in their area, but really get through to someone and almost never are able to connect via call. So just any tips that you all had. I'm looking at, I saw another one came in about partnership, but we can start there. It's really for both of you to address.
I will be transparent that the development of these partnerships predates me being in this role. So these were developed prior to me running these programs. I do think that when we first partnered primarily with Grand Rapids Public Schools, that our CEO has a relationship with their superintendent. So that may be something to inquire about. Sometimes they're in similar kind of professional circles. Although I have had some luck, honestly, going to the school district's pages and filling out the forms. Yes, it doesn't always yield an immediate result, but I did this for some school districts in our more rural areas and eventually did get in contact with a school nurse. But the school nurses actually might be your best person to get in touch with first, because they can really advocate to the superintendent for you to try to get a meeting. But yes, a lot of these communications probably unfortunately do go unanswered. And so it may be more of a networking need to develop that kind of first line of communication.
Yeah, sounds like something that also takes time to build that rapport based off of what you're saying. And Dr. Chow, the very similar question that came in during your presentation asking if you could speak more about developing those community partnerships and any specific recommendations that you have as far as like where you can start to look for opportunities, who's best to connect with.
I appreciate this question because our complete foundation of our organization is based on community partnerships. And so we don't exist without those community partners. I am very fortunate in the sense that I had a private practice in the town where we got started prior to this. And so I already had a lot of networks within the community. We did start with a superintendent instead of starting from kind of the ground and building towards the superintendent. We started at the top because he has the ability to kind of enact things. And then from there, we work with the principals and the school nurses, as well as our school-based health center. That partnership grew from our federally qualified health center. And I reached out directly to them and just kind of talked to them about the importance of vision around pediatric vision and pediatric eye health and access. And so that was, they acknowledged that the need was so great as well. And so we were able to partner and provide those services directly at the school-based health center, which I think is a huge win.
No, that's amazing. Yes, please connect with your school-based health center colleagues for those attendees. So the next question, Dr. Chow, this came in also during your presentation. I'll open it up to both of you, but if you want to start, that would be great. Does the opt-in model hold up exams that otherwise need to be conducted, or do you think that the opt-in on paper is better? Is there an electronic or texting method, or what do you find works best?
So for us, we require opt-in because we dilate our patients, and so we must have consent from the families. And because of the relationship with the partner organization, they're the ones who distribute those consent forms on our behalf. We also have them downloadable from our website. So if for some reason parents just want to go to the website, because we will take patients who will direct refer, they don't have to fail a vision screening in order to be seen through our program. So our partners will announce that we are coming to the school. The partners do prioritize those students who have failed their screenings and don't have established providers, but then it's opened up to anyone who wants to self-refer. And like I said during my presentation, I love that the majority of the parents come to the exams at the scheduled time with the student. I think that's huge. And so the opt-in gives them that chance to attend that appointment with their student.
Thank you. That's great. Dr. Baker?
You definitely want to have an opt-in. We do a dilated exam also, but even with an opt-in, we sometimes do get upset parents. Even though they did opt in, even though they did complete a consent, they don't recall it or don't remember it. And so they're upset sometimes if they're, they felt like they were not in the loop or things like that. So you definitely do want an opt-in consent. I feel like with an opt-out consent, you may be having many, many complaints from parents that sort of missed that message or didn't understand that during enrollment. So to save yourself some stress and headache, I definitely, and because I think the services warrant it, would also definitely recommend an opt-in consent.
I also want to add for our program for the students that parents don't arrive for their exams. We do call the families at the conclusion of the exam to report the results of and findings of the exam.
Oh, that's great. Thank you. Thank you both. Dr. Baker, this question came in during your presentation, but certainly open to whoever wants to answer. But can you talk about how you handle follow-up visits? Do you return to the school, or do the follow-ups get referred back? And also thank you to both of you for the presentation they added as well.
Yeah. No, so we do not return to the school for follow-up visits. The follow-up visits are done at our brick and mortar clinic. And I will share that we are in an urban area, so none of our partnering districts are a significant distance from our brick and mortar clinic. But when a student does require follow-up, so parents are not present when we do our exams. We do not pre-appoint. We know the kids we need to see, but we will pivot day to day based on testing and things like that to make sure that we get through the kids in a certain amount of days. So there's no way we could possibly have parents present. But if a follow-up is needed, we call the parent. We do 3 attempts basically to contact the parents to get that follow-up scheduled, and they're seen in our brick and mortar clinic for amblyopia, strabismus, and things like that. If a referral is needed to ophthalmology for some reason, then we go through our standard process for ophthalmology referral. And if we can't contact them, then we again send another letter home. What's going on? We need to see the child again. Please contact us. And things of that nature. So we unfortunately can't go back to a school to do a follow-up for one child. So they are seen at our brick and mortar clinics.
Thank you. All right.
Did you want me to answer that as well?
Yeah, if you wanted to, that would be great.
Okay. Yeah, because I think Dr. Baker pointed out made a really good statement in that hers is in a much more urban location, whereas we provide much more rural care. And so we do return to the school to provide follow-up care, but we also use a community health worker to reach out to the families after they've been seen to find out if there are any problems or if they need any supportive services. We also are set up in the rural health clinics adjacent to the school. So if we have just 1 or 2 students that need follow-up, we will have them come to the rural health clinic to see us there.
Thank you. Both those perspectives were awesome. So thank you both for sharing. Dr. Chow, in addition to clinical staff who are providing services in the schools, how many dedicated administrative or clerical staff do you have to do the pre and post event work to support your team in those efforts, like checking insurances, placing orders for glasses, any type of patient tracking, as well as like for your grants? So what does the rest of the team look like for that level of support?
So the support at the actual schools, we typically just require 1 person. That's kind of our liaison, and she or he will get things set up for the clinic day, as well as scheduling the patients. We do all of the insurance verification on our end, and it's just myself and my assistant.
Wow, so wearing multiple hats. Thank you for sharing that. Another question came in, and both of you can respond to this one. Do any of the doctors or staff volunteer their services in support of these programs?
No. All of my doctors and staff are employed by our health center.
I would love to say no so strongly like Dr. Baker. However, I do donate all of my clinical time. I am paid as an executive director part-time, but because we are such a new organization and still building ground, for the time being, the grant goes to support the actual clinic itself.
Thank you both again. It's just amazing having the two different perspectives, two different communities that you're serving. So thank you both for responding to that one. Another one that both of you are welcome to respond to. But Leah wanted to know, can each speaker talk about the equipment that they use?
Did you want to go
Yes,
first?
I can. I think our equipment's fairly similar. So we use a mobile phoropter. So they make a stand that you can attach those to that you can move around. We do use a barber chair, like it goes up and down a little bit. I don't think that's totally necessary. I think you could probably use any chair that you wanted, but since kids are so small, it gets them to a little better height, like more comfortable for the doctor. But again, like from a program startup standpoint, I don't think that's necessary. And then we use a binocular and direct ophthalmoscope. Our bus has slit lamps. Our in-school program does not. All of your regular handheld ophthalmoscope, retinoscope, and then it sounds like both programs use the M&S visual acuity systems. I think probably both on laptops where you can calibrate the distance to get accurate visual acuities. And yeah, most the same exact equipment we would have in our brick and mortar, except we don't have a slit lamp with our in-school team. We do have a handheld slit lamp, but that gives a little more limited exam.
Just like Dr. Baker said, we use all of the same. Our phoropter and phoropter stand actually comes in a suitcase. It's called a Rush phoropter, which is made here in Oregon, but it has an electronic up and down. So it has a pretty big range, so we can use standard chairs. If a child is too small, sometimes I will have them stand at the phoropter, and that works too. We do use also a retinal camera, and we do take photographs of retinal photos of every student that we see.
Thank you. A question came in about connectivity. So Dr. Baker, um, I'm gonna give you this question. I think it's a bit timely. But the attendee said that they work for a mobile vision provider in St. Louis, and they serve some rural areas in the metro area where internet connectivity can be spotty. And was just curious if Cherry Health had experienced this, and if so, how have you developed any successful offline solutions for doing the work?
So on our bus, we do have a company network that was, again, like one of those unanticipated costs, not inexpensive to install, like a actual secure network on our vehicle. And yet it is still a little bit spotty. So we do have downtime forms. Essentially, we convert to paper for the short term, where they're filling out, a paper exam form and putting things in after the fact. We don't usually go down very long. If we have a outage, it's usually just related to needing to reset the modem or router or whatever you have to reset. Usually if they turn it off and turn it back on, the connectivity comes back. So that's not normally a huge issue. It's just sometimes we'll lose connectivity with our printer or something like that on our bus. And so, yes, definitely can be frustrating for staff and definitely not a really efficient process, but kind of the only solution that I think that there is on a mobile unit.
Understandable. We have so many questions. We're not going to get to all of them, but I encourage for all the attendees, please continue to enter your questions, and we can certainly share that with the panel after and see if in the follow-up we can provide some clarity on some of those. So I'll just do one last question. From Mary. She said that she's a new school nurse at her school, and she really wanted to know how she can attend like online classes or what resources are available to support vision screening for her students, if you have any recommendations. And that can be to whomever wants to answer.
I will, oh,
Oh.
sorry.
No, go ahead.
I'm not sure what resources you might have. I do know that our local Head Starts did receive some grant funding for the spot vision screening devices, and those are fairly easy to use. You just have the kid a certain distance away, it checks for a prescription, and you get a like green circle or red circle, like a pass or fail type of thing. So that might be a good jumping off point in addition to just using like wall mounted chart for screening kids. And I think that's my only recommendation. I don't necessarily have any resources.
I would say something very similar. I'm not familiar with screening resources for school nurses, but the spot vision screening device we have used in our private clinic for 10 years, alongside with cyclopleging every student that we saw what we used with the spot. And I would have to say that that screening device has some very strong capabilities and does an excellent job screening the students. Now, I would never prescribe off of the numbers that are given from that device. However, they do a great job of saying, does this kid need further care, or did they pass their screening? It's pretty reliable. And it's, like Megan said, it's very easy to use, very user friendly.
Awesome. Thank you so much to both of you for just going through all of the questions. I know there was a lot that we didn't get to, but I encourage all of our attendees continue to drop those into the Q&A box. And we hope to be able to follow up on some of those in our follow-up communication. So Harper, I will turn it back over to you.
And I was muted, but I'm back. Thank you so much, Danielle, for moderating that. And again, I know we got so many great questions, and I just encourage folks to continue to put those into the chat so that we can go ahead and send you resources and follow up with emails so that you can reach out directly to our lovely speakers. I'm going to go ahead and launch our closing evaluation poll. This helps us know what content we should improve upon, things that you enjoyed, and things that we can continue to provide you with. So just let us know how everything went. We'd love to hear your feedback. I'm also happy to share that registration is now open for our conference happening this summer in Washington, D.C. from June 23rd to the 25th. It'll be super fun. Danielle and I will both be there, and it would be great to see folks in person. So if you scan this QR code, it will take you directly to our registration form, and you can learn more about conference as well, like including workshop information, who's going to be there, who's going to be presenting, what things that we'll be hosting in DC, and more information on our website, so check it out. We also encourage folks to stay up to date about amazing sessions like this that are coming your way in the future by subscribing to our digest that goes out every other week, following us on social media, and yeah, thank you all so much. We are so happy that you're able to join us this afternoon. And again, we will be following up next week with recording and slides.